Hello, my name is Faintola Bankole, and I'm presenting my research proposal on improving health outcomes for deaf individuals. This study explores the barriers faced by deaf individuals in healthcare settings and examines how language proficiency, intermediary support, and subgroup differences influence health literacy, trust, and self-efficacy. To begin, deaf individuals face unique barriers to mental health services, including lack of interpreter access and culturally competent providers. Many individuals feel shame or uneasiness when it comes to interacting with healthcare providers. So why is health literacy important to the deaf community? Health literacy is defined as the ability to access, understand, and use health information, and it's crucial for making decisions such as choosing treatment plans and following through with them. Groups with lower education and English proficiency tend to have lower levels of health literacy and therefore poorer health outcomes. My research focuses on three key factors impacting health outcomes for deaf individuals: language proficiency, intermediary support, and subgroup differences. This study aims to investigate the relationship between ASL proficiency and health literacy, examine the role of interpreters in improving healthcare access and trust, and explore how subgroup differences within the community impact outcomes. The first theme I found during my literature review was language proficiency. Education and language proficiency are linked to improved health outcomes. These studies showed that higher education improves health literacy in populations with language barriers. Limited English proficiency increases stress and worsens health outcomes, and there is a strong correlation between ASL proficiency and English reading skills in deaf individuals. This suggests that language education in ASL and English enhances health literacy. The next theme is intermediary support. Intermediary support, particularly interpretation, plays a key role in bridging communication gaps. These studies show that low English literacy and limited access to interpreters create significant barriers for deaf individuals seeking healthcare. Access to interpreters that understand deaf culture can build trust and improve patient-provider communication. And overall, intermediary support can facilitate help-seeking behavior. These findings reinforce the idea that higher quality interpreter services and cultural competence improve trust and healthcare outcomes. The last theme was cultural differences or distinctions between subgroups in the deaf community. Generally speaking, cultural differences shape perceptions of health and in turn health literacy. One study found significant differences in health literacy between Korean and Vietnamese immigrant subgroups, highlighting the need to tailor support to diverse needs. Another study observed that lip readers and those with less ASL education faced greater challenges. These findings support the idea that subgroup differences such as communication modality and education level influence healthcare needs and outcomes. Based on this review, my study proposes three hypotheses. The first, ASL proficiency coupled with formal education in both ASL and English will predict better health literacy in deaf individuals. The second, quality of intermediary support will predict the level of trust in mental health providers from deaf individuals. And the third, ASL users with mixed educational backgrounds are more likely to have high self-efficacy when seeking mental health services. This study uses a natural groups correlational design to investigate how ASL proficiency, communication modality, and education influence health outcomes. Independent variables include ASL proficiency, formal education, intermediary support quality, and educational background. The dependent variables are health literacy, trust in mental health providers, and self-efficacy. Participants will be recruited for this study via deaf community organizations and social media. The survey will be housed in an online platform such as Qualtrics. Informed consent will be provided in ASL and English for accessibility, and the entire process should take around 30 to 45 minutes. Participants will see a demographic questionnaire followed by 5 established scales: the ASL SRT, the S-TOFLA, the Outpatient Mental Health Survey, the Trust in Physician Scale, and the General Self-Efficacy Scale. The study will use a convenient sample of 150 deaf individuals aged 18 or older. Participants must have prior experience interacting with the U.S. healthcare systems, and demographic diversity is critical to capture varying experiences. This includes age, gender, ethnicity, and communication modality to reflect the deaf community. Example items from the demographic questionnaire include: what is your primary mode of communication? And how many years of formal education have you received where ASL was the primary language of instruction? The ASL SRT will assess ASL proficiency. It consists of 20 sentences presented via video in ASL, with participants recording themselves signing each sentence in response. The ASL SRT has strong reliability, with a Cronbach's alpha of 0.9. An example sentence from the task is: my last vacation was 7 years ago. The S-TOFLA evaluates health literacy. The test includes 36 multiple choice items, requiring participants to fill in missing words to assess their comprehension of health-related instructions. The S-TOFLA has a high reliability, with a Cronbach's alpha of 0.97. An example item is: take 1 tablet by blank every day. The Outpatient Mental Health Survey measures patients' experiences with mental health care services. It contains 37 items using a mix of forced choice, checklists, and Likert-type responses. The last 8 items have been adapted for use in the demographic questionnaire. The survey has a Cronbach's alpha of 0.85, and an example question is: how well did the phone or video visit work for you? With response options ranging from not well at all to very well. The Trust in Physician Scale measures trust in healthcare providers. The survey includes 11 items rated on a 5-point Likert scale, where 1 is strongly disagree and 5 is strongly agree. The modified version shifts focus from general physicians to mental health providers. This scale has a Cronbach's alpha of 0.85, and an example item is: I trust my provider to tell me if there was a mistake made about my treatment. The General Self-Efficacy Scale assesses confidence in one's ability to cope with challenges. The modified version focuses on self-efficacy in seeking mental health services. It includes 10 items rated on a 4-point Likert scale, where 1 is not at all true and 4 is exactly true. It has a Cronbach's alpha ranging from 0.76 to 0.9. An example item is: I'm confident that I can find mental health services when I need them. Based on past research, I am anticipating a positive correlation between health literacy and formal education in both ASL and English, a positive correlation between the quality of intermediary support and trust in mental health providers, and a positive correlation between mixed educational backgrounds and self-efficacy in regards to seeking mental health services. These findings will inform policies to improve interpreter access and cultural competence in healthcare, ultimately enhancing health outcomes for deaf individuals. This study's limitations include reliance on self-reported data, which may introduce bias, as well as limited qualitative insights, meaning personal experiences might not be accounted for. Additionally, findings may not be generalizable to all deaf subgroups. Additional subgroups may include cultural identity, number of deaf family members, and maternal education level.